Hi, as Sean said, I'm a clinical medical physicist. I work at the Beacon Hospital, and I signed up for a part-time PhD, which is a collaboration between UCD and the Beacon Hospital. So in the Beacon Hospital, we treat liver tumours with stereotactic ablative radiotherapy. In the world of radiotherapy is relatively new, and the advances in technology in radiotherapy have allowed us to treat these tumours to a very high dose while sparing the organs around it. And in particular for the liver, so we can treat now partial doses of 100 gray or more and still be safe with our treatment. So you need to image, treat very conformally, and we need to do some sort of motion management on these tumours. And this slide shows that you can get quite a good local control with this type of treatment if you can give quite high BEDs. So the whole treatment planning process in radiotherapy involves simulation, where a patient comes in and they have a CT scan or an MRI scan with that also sometimes. There's organs at risk that are near the target area are manually contoured, often manually contoured. This is often done by a dosimetrist, a physicist, or a physician. And then the target is usually contoured by the physician. And then it goes on for the treatment planning and then on to treatment. We find, and in many clinics, I think people find that there's often quite a delay in the physician availability for the manual contouring of the targets. And like recent papers have shown that this whole process is moving towards automation. And in MD Anderson, they have a fully automated treatment planning system. They did this in mind for low resource clinics. Many of them in the third world were having an advanced cervical cancer treatment like this would be such an advantage, where they don't have the resources that we have. But they've also moved on now, and they're doing it for VMAT planning with very little physician input. Just have to check some of the contouring. And I think this is the way radiotherapy is going to go. So in the Beacon, when a patient is having this high dose of radiation to their tumour in their liver, we give them a CT scan with contrast, and then we also give them an MRI with several different sequences. And currently they contour, the physicians, some of them are here, contour the CT plus contrast, and they also contour on the MRI sequences. And this is because we find that sometimes the CT with contrast is not high enough. We can't see the tumour well enough on them to contour just on the CT. So some of the more traditional or some of the ones that are available, the auto-segmentation techniques, are intensity-based or they're atlas-based. And in the liver area, you can see here, the liver tumour is quite, there's not a great difference in the gradient between the surrounding tissue and the liver tumour itself. And then in the lung, you can see that some of these intensity-based methods or atlas-based methods would work very well. Also in the liver, you've got a lot of deformation. Bowel filling, as Uwe showed earlier. I mean, people have bowel motions every day, sometimes more than every day. And like, how can you know when you're treating these patients what their liver is going to be pushed with, whether it's stomach, bowel? We see it every day in the clinic where we have trouble treating these liver patients. So the idea, and also they move with respiration. So this is another problem. And this also gives artifacts in a lot of the images. We try and scan the patients and treat them in end expiration breath hold, which we find is more reliable. A lot of these techniques as well are moving towards the adaptation on set. And as Uwe was saying earlier, it's a process that is time consuming. So auto-segmentation is definitely a vital part of this whole process. And as far as AI and deep learning goes, this was in a paper, a review paper in medical physics from the AAPM, and it shows that there's basically an exponential increase in the amount of peer-reviewed papers on medical imaging and deep learning. So for my project, we want to use liver images and auto-segment tumours using convolutional neural networks. And a convolutional neural network has an input and an output and several hidden layers, and you train it. You need data that's labelled to train your network, and then you need a test data set to test your network. So this was one that was done with a knee MRI, and then you can see the segmentation coming out on the right. If you go to any of the conferences in radiotherapy, physics, or AAPM or ESTRO, you'll see this UNet everywhere. And it's a very good architecture for auto-segmentation. And you have to encode and decode, so you have to get back to your spatial resolution. It's not just a classification issue, so you want to get back to the original image and have your segmentation on it. And I propose to use Keras and a UNet for the task. And some of the challenges that I see in this project, ethics and data is a huge problem, and getting labeled data, and also access to the computers that you need for this. So we're talking about using maybe iCheck or some of the resources that are available by collaborating with UCD. And then some of the questions that I'd like to see is how the network would perform if it's trained on non-contrast images and then contrast-enhanced images, and comparing them. And like, what happens when you've got images that a lot of physicians, I think, don't like it when they have to edit contours constantly. I think it's even more time consuming than contouring them from the beginning. So if you've got artifact in your image, and if you've got pre-treated areas and fiducials, how would this affect your contouring? And then also, probably not going to have a huge data set, so how do we overcome the issue of overfitting with small data sets? That's really the research I'm doing, so thank you.
Brilliant.